Okay, so Francis is a member of the AV staff here at the Hyatt, who's 24 years old. I met him yesterday because we had two patients lined up, one for the morning, one for the afternoon, and both bailed. So Francis is stepping in. So his history is this, and we've spent about, Mark Kazuki and I spent about 2 minutes looking at him to make sure that there was going to be something to show, but we have not done a formal exam, so we're in this together. So 6 months history of aching pain with reaching overhead, mostly in forward flexion and abduction. No trauma, but he was doing a lot of breakdancing at that time. His pain is worse late at night before he goes to bed and early in the morning when he awakens. It feels better when he stretches it a little bit and it loosens up. He has pinching, that was his word, between 90 and 150 degrees. Those are my words. And he felt that he would feel a click at 150 degrees of elevation, and then he feels something release. He has some weakness with lifting, but that's intermittent. He didn't really describe any instability events, but his shoulder doesn't quite feel right. It's when I asked him about feeling whether it's going out of joint. He has no tingling or numbness, doesn't have any loss of motion. It doesn't wake him up from sleep. And as I said, it improves when he stretches it or loosens up. And it improves if he avoids reaching overhead. Okay, so that's our history. Does that pretty much summarize it? Okay. So come on up, Francis. We are indebted to Francis. Okay, so if we could switch to my lavalier mic. Shirt off, please, and shoes off as well. And we'll see if we can show some stuff. And Pat, I need you and Nick and Mark to be watching, so then you can, socks as well, just in case we see something down there. And thank you for coming. I do appreciate it. Okay, so let's just take a look at him. I'm going to step off the stage and see if I can make some observations. Okay, so what I'm seeing from here is his right shoulder is depressed, his right clavicle is low, nipples are actually about the same line, but his hands are in front. Not much to show you right now in his feet, so we won't have to change his position. If you would turn to your right, please. Okay. So again, arms are out in front, his scapula are a bit internally rotated, I think slightly anteriorly tilted, his chin is probably at the right level. Head and neck forward a little bit. His back is a little bit flat. I'm not seeing very much in the way of pelvic tilt. And now if you would make another turn to the right. So now looking from the back again, his shoulder looks, right shoulder looks a little bit low. He looks like he's got a little pelvic asymmetry. If I look here, he's coming in a little bit more on the left than on the right. I'm not seeing a significant amount of tilt. Most of the therapists sitting in here would be better at that part of the exam than I am. Both feet are a little bit externally rotated. They can pan down where we are now, but and his hands are out in front of him. So if you would put your hands on your hips, please. Okay. So when he does that, there's a little bit of asymmetry here. Here's the inferior medial border of his left scapula, inferior medial border of his right. So the right is a little bit low, a little bit laterally translated. I'm not seeing a lot of anterior tilt. Go ahead and put your hands down at your side, bring them out, just go out to the side, up and overhead 5 times. If you would, just do it quickly, if you would, Francis. And in Ben Kibler's lab, they've shown that on EMG, the muscles, the periscapular muscles will fatigue with 5 repetitions. So we'll do, I mean, I don't always do this in the office, but as you watch him, his right scapula is changing with each repetition. So now if you would bring your arms out to the side, up and overhead. Okay, and now bring them down slowly. A little slower than that. Okay, so his medial border is winging. So he's got Ben Kibler's type 2 scapular dyskinesis. Now go forward, and I usually see it eccentrically coming down from forward flexion more so than abduction. So bring your arms straight in front of you, and then you can see his scapula moves out laterally very early. And now you can see there's an asymmetry because this side is out farther than here. And now bring them down in front of you slowly. So there's clearly a side-to-side difference. So now, if I do his, so I've looked at his scapulohumeral rhythm. You weren't having any pain coming up? Okay, so there's no reason to do the scapular assistance test. Elbows in, push out against my hands. I'm sorry, out towards the sides. Okay. And I can't tell, is he winging? Good, push out. Okay, all right, and now we'll test him up here. Push up. Okay, a little bit, not very much. Go ahead and push up again. Okay, and then let me just show you, he doesn't really have much in the way of weakness, but I'm just going to bring your arms down, turn to the right. The way I would do my scapular assistance test actively is have the patient bring their shoulder blades back, but the way I cue them is just lift your chest. Now his scapulae where they belong, rather than having him pull his arms back, which is what you saw in the other video. So I'd have him do that, and then test him again, push out, and then bring your arms up, and push up. Okay, and the way Ben Kibler does it, go ahead and drop this one down, both of them down, it's fine, is he does it passively. So he'll put his hand over the patient's coracoid, use his forearm on the scapula, and then resist external rotation, and then resist them up here. And if I have to, I'll go that way. The reason I do it actively, and this isn't to debate Ben while he's not here, the reason I do it actively is I'm teaching the patient that if I can cue them to bring their chest up and I can change their rotator cuff strength, if it's an athlete, I can get them to buy into it. Okay, so those are the corrective maneuvers that I do. Then we'll have the core and lumbopelvic assessment. If you stand on your left leg, okay, so he's got a little bit of a problem with core stability, and now do a little partial squat. Okay, so he's got some gluteus medius weakness. He can't control the external rotation of his hip, and now stand on your right and do the same thing. Okay, I'm going to bring you back between these two tapes, and if the guys on the camera can show his feet. Perfect. Okay. One of the things you have to be careful, you have to watch when you have them do single leg stance and single leg squat is what's happening with their arch. Because if the problem is, if they're collapsing their arch when they stand and going into pronation of the midfoot, then the problem is down there. It's not at the knee and it may not be at the hip. So you've got to look at the entire kinetic change. So let me have you just stand on your right leg. Actually, you know what? Let me just turn you a little bit, Francis. Right about there. I think that'll be fine. And stand on your right leg. Great. So now you can see his arch, and we'll see if he does demonstrate it. And go ahead and do a partial squat. And his arch does come down a little bit. He's correcting it. Come on back up, and just do it one more time. Yeah, he's able to correct it. But if it was somebody who totally collapsed, then what I would do even in the office, because I have so much time to see patients, because I only see 4 a day, is I take something from under the table, roll it up, and put it in his arch, and see, do I eliminate the collapse of the hip and femur? So we sometimes will look down there. As I narrate this, I tend to forget my rhythm of what I'm doing. So we've looked at feet, core, and lumbopelvic. One of the things with his arms, let me just bring you over to the left again. One of the things that I'll look at when somebody's got their arms in front of their body and he's out a little bit is I'll put him where he belongs to get a feel for, is it correctable? So especially in a thrower. So when I'm going to play with his right arm. If I put his arm where I want it, that's where his scapula belongs. I've pulled it up a little bit. I've posteriorly tilted, externally rotated it, and I'm bringing it up. His arm goes out to the side, which tells me that either his rotator cuff or his deltoid is too tight because something is causing it to come out. So I want to make sure that, and with the therapist that I'm blessed enough to work with, I don't have to tell them about looking for soft tissue stuff up front, but just not everybody's as fortunate as I am when it comes to that. So I'm looking at that, and that's an indication of soft tissue stuff that has to be corrected. So that's pretty much my observational exam for the kinetic chain. I've tested his rotator cuff already, and then provocative tests you can do either sitting or standing. And the choreography that I use is I'll bring the arm, and if I do anything that hurts, just tell me. Test horizontal adduction, and I'm looking for, is the posterior capsule tight? Does he have pain at the AC joint? Bring him into, do a Whipple's test, push up, which is for anterior supraspinatus. From there, I'll go to the O'Brien's test, push up, pain there, okay. And if he's painful in that position, if he's not painful in that position, then I don't have to do part 2, which is in supination, which is to look for AC joint problems. Push up, better? Okay, so he's got a positive O'Brien's test, and then I'll bring him, that's in 20 degrees of adduction. Then I'll bring him out in front, push up, palm up, push up. Is that okay? Okay, so his biceps provocation and forward flexion speeds test is negative. Push up, palm up, and an abduction, that's okay, negative. And then from there, I'll bring him into the apprehension position. Pain there. Okay, push forward. Okay, so he doesn't have impingement in the 90-90 position. And then I'll do a Hawkins impingement. No pain there. Okay, so basically his provocative tests are all negative except for his O'Brien's. Anything else that you guys want to do standing?
No,
Can we have Dr. St. Pierre's mic, please?
I think, are we good? A lot of this, there's principles and then there's techniques. So there's going to be different techniques between different providers. I think they're all right. It's just what you tend to do. For me, instability testing, I do better at supine. So I won't go through a lot of the instability testing on this patient. I wait till I have them in a supine position. The only thing about the history, do you work